So this is the first session today, and I will discuss actually the anatomy, physiology, test of thyroids, scintigraphy, ultrasonography, final aspiration, biopsy, and non-thyroidal illness. Please, for everyone, these tools, files, and videos are not for redistribution. This is for personal use. Even if someone records this session, I agree to use it personally, but not for redistribution. First of all, this is not an academic presentation. This is an interactive presentation. So any questions are welcome at any time. You can stop me and ask at any time. And scenarios need interactive discussion from all of you to get the benefit. So if anyone has a question, please let me know.
Assalamualaikum, Dr. Khalid Yusuf.
There is a problem in voice. I want to check it, please.
Dr. Khalid Yusuf, I want to ask from you that the topics of you discuss about thyroid, like Graves' ophthalmopathy, from where we will have to read it? From Oxford book? It will be
I
enough?
will mention this. This is Oxford and another resources. You will see it immediately. But actually, I want to check the voice. Is the sound is clear or not?
Yes, sir. Clear. It's clear.
Okay.
It's clear.
So first of all, I want to
Voice is
thank
clear
a
to us,
lot
but
of
I think
our
it's not
previous
clear to
members.
somebody.
Yes. Yes. Okay.
I'm saying the voice is clear to us, but it's not clear to some of the people.
Okay, I think as someone voice is clear, so this is a localized problem for some persons. Maybe the internet connection is slow there. So first of all, I would like to thank a lot of our mentors actually. دكتور محمود عزت ما ينفعش الواحد غير ما يشكره بصراحة. محمود عزت، ابراهيم الآلي، دكتور خلدون، سفيان، أسامة، أحمد، مصطفى، عبد العزيز، منشة، راجاموندي، باكاي، and also دكتورة نيرة، روبان خان، الدكتورة رنا from Iraq, الدكتورة أمل, of course جوبتا, الدكتورة إيمان, الدكتورة سمر, and one of the pioneers in English and endocrine actually الدكتورة ياسمين, أسماء, نانسي, and all of previous members of this interactive discussion. So thanks for all. And actually, I will start chapter by the chapter. Inshallah, this is the thyroid chapter. After it, if I continue, I will continue with the pituitary and adrenal reproductive, and then calcium, and then diabetes. And actually, diabetes, as it is a very important, I can prepare a session for diabetes for every month, because this is very important. Actually, let it discuss it later, inshallah. So I will discuss today anatomy, physiology, thyroid function test, scintigraphy, ultrasonography, fine needle aspiration, biopsy, and non-thyroidal illness. Or from the page 1 to 25 from the third edition. And if you have a fourth edition, actually, the available edition, fourth edition in the Egypt, it is not a true PDF. So actually, I not prepare all the session from the fourth edition, but each modification in the fourth edition I included in our course. So I will discuss from page 1 to 30, page 30 from the fourth edition, which is not as a true PDF. So from page 1 to 25, or from page 1 to 30,
Excuse me,
non-true
doctor.
PDF, fourth edition. I will cover
Excuse
the
me,
following
doctor.
topics in the following session. Yes?
can we take a screenshot for material, or I will find it?
Yes, you can take it for personal use, even if you record it. And actually, I will send this the first session for all of you, and don't worry.
Okay, thank you.
And even if you record it, not this session, I will upload it immediately. But for another sessions, if anyone records them and don't share in our course, he can use it personally, freely, without any fees. I
Okay,
will
thank
cover
you.
the following topics. Actually, this is a very important session, because in the final exam, at least 6 to 8 questions from this session. So for everyone, it is mandatory. And actually, this is not a pro edition of the Zoom. So they mentioned that running out of time 10 minutes. And after termination of this, you can join again. I hope it complete. I pay another one. We will cover the simple anatomy and development of the thyroid gland, the physiology and sense of thyroid hormone, and hypothalamic pituitary thyroid axis, conditions that affect TBG. This is a very important condition, and the most important is the iodinase enzyme. It types and their role in the pathological condition, thyroid hormone resistance and differentiation between it and its trauma, drugs that affect the thyroid function test, FDH familiar dysalbuminemic hyperthyroxanemia, thyroid scan and ultrasonography, which is U classification, and fine needle aspiration cytology, which is Psi classification, and non-thyroidal illness. Actually, this is a very important topics. The anatomy and histology is not very important actually in the exam, but you need to know that thyroglobulin is presented in the lumen, which is filled with thyroglobulin, and the peptide sequence of T4 and T3 are sensitized and stored as a component of thyroglobulin in this position. Are you ready for exam? I hope from everyone from today to solve some questions daily, like the exam. And actually in the exam, this is one question like the questions in the exam. And I suggest for everyone to get benefits from the time, because some questions, the head of the questions can be answered without reading the scenario. Please first read the question he posed. Don't read from the beginning of the scenario to know what the question asks about. At least to search for some words, some points to answer question immediately. Yes, yes. So in this question, during embryological development and so on, please stop. Read the question. The embryological origin of the parafollicular cells of the thyroid gland is from which one of the following source. So in this case, you can answer the questions correctly without lose your time with reading the scenario. So which is the correct one? Actually, the correct one is a neural crest. In the final exam, there are some questions like this needs to test your knowledge about the basic science, physiology, anatomy, embryology, and so on. So this is a difficult question actually, except if you read it and know it. So the origin of the parafollicular cells is from the neural crest endoderm germ cells. So the development of the thyroid, it is developed from the endoderm of the floor of the pharynx. It is mainly from the foramen cecum, and the parafollicular gland, the parafollicular cells, mainly originated from the ultimobranchial body, which is originated from the fourth pharyngeal pouch. Fourth or fifth, there is another some references. They mentioned that it is from the fifth pharyngeal pouch, and actually the fifth and sixth pharyngeal pouch are compromised within the fourth pharyngeal pouch. So the correct answer, and ultimobranchial body, this is believed to originate from the fifth pharyngeal pouch, which is infiltration of the cells migrating from the neural crest. So the origin of the parafollicular cells and the parathyroid gland, ultimobranchial body, fourth pharyngeal pouch, dural crest. This is all are correct. Don't forget that C cells are the source of the calcitonin, which is may arise in medullary thyroid carcinoma, and this is a tumor marker calcitonin for diagnosis and follow-up of the medullary thyroid carcinoma. C calcitonin, medullary thyroid carcinoma. This is very important. Another very important topic, which is the fetal thyroid begin to graphile iodine at about 10th week of gestation. And here in the third edition, they mentioned that the maternal TRH readily crosses the placenta, maternal TSH and T4 don't. Don't forget this. So TSH and T4, they mentioned that don't cross the placenta, but the TRH readily cross the placenta. This is modified in the fourth edition. They mentioned that the maternal T4 cross the placenta at a time when fetal thyroid gland is non-functioning. So in the previous edition, they mentioned that the T4 does not cross the placenta. In the fourth edition, they mentioned that the T4 cross the placenta. What is the correct? Actually, both are correct actually, because I searched for it. This is from a very important source, which is thyroid disease pregnancy, and they mentioned that the TSH does not cross the placenta. T4 and the levothyroxine actually cross the placenta by a different percentage. Actually, before 20 weeks, they cross the placenta, and fetus depends mainly from the mother's thyroxine, and after 20 weeks of gestation, they depends mainly on the fetal thyroxine. And T4 from the mother will be inactivated by the iodinase S3 in the placenta. A TSH receptor antibody will pass the placenta and cause a neutral thyrotoxicose and fetal thyrotoxicose. Iodine actually cross the placenta and can affect the thyroid of the fetus. Radioactive iodine distract the fetal thyroid gland. PTU and mesimazole can inhibit the fetal thyroid because they pass the placenta and cause drug are teratogenic. Propranolol also pass the placenta. So,
Dr. Khalid,
yes.
you know the Eltrox in which we give the levothyroxine, the tablets,
Yes, thyroxine tablets, yes.
they can cross the placenta. Like that's why we give it to the pregnant ladies. Yes.
Yes, yes, it crossed the placenta by to some amount. I will show this in this very important slide. This is the T4. T4 from the week 20 will be the maternal T4. Actually, the maternal T4 will degrade by placental type 3 deiodinase, and we will discuss it. So you must know that levothyroxine or maternal T4 can pass the placenta but by not a same percentage through the gestational age. So in the first 20 weeks, the fetal depend mainly on the maternal thyroxine, but after 20 weeks, there is a share from the maternal thyroxine and fetal thyroid hormone production because the hypothalamic pituitary thyroid axis of the fetus will begin to sensitize thyroxine from the week 20. And this is, we will discuss it in the thyroid disorder during pregnancy and postpartum later on. I will go to another question actually. This is another question similar to the exam. An 18-year-old male, I will go to the question directly. Which of the following is the most appropriate long-term management of this condition? So you need to diagnose and to know the management. So a lot of question in the exam depends on your experience and your preparation. So here in this scenario, they ask about a long-term management. So what is the diagnosis? And after you diagnose the case, you need to know the long-term management. 18-year-old male present. If anyone want to read the question, it is welcome. But I think Zoom will terminate it and we will join again after a few minutes. So if anyone want to read the question, as I mentioned previously, we need the interactive discussion. Okay. Actually, the voice is not clear. So it's okay. I will read. I will read.
An 18-year-old male presents to the endocrine clinic for review. He has a midline cystic neck mass, which
Yeah, but
he
once we
says
see midline cystic mass, we must suspect the diagnosis. It may be thyroid nodule. It may be a cystic mass. It may be lymph node. So we need to diagnose which one. Okay.
mass the past year and does not cause any.
So examination reveals a small cystic mass slightly to the left of the midline adjusted to the thyroid membrane. The mass appears to move with swallowing, so it is a thyroid mass or well demarcated cystic mass. CT scan of the neck confirm a small, well demarcated cystic mass. So the diagnosis is thyroglossal cyst. Which of the following is the most appropriate long-term management of this condition?
Surgical excision.
Surgical excision.
Yes, this is the correct one. So the surgical excision is the preferred option for the treatment of thyroglossal duct cyst. So the case scenario, you can go to the diagnosis, which is thyroglossal duct cyst, and of course this is need to be managed surgically. No medical treatment for thyroglossal cyst. So, and this is the CT scan for the thyroglossal cyst, and actually in the exam there are at least about 30 to 30 imaging questions, so they can put CT or MRI or PET scan or continuous glucose monitoring diagram, and can mention retinal photo and so on, and ask about this image, or to simplify answer the question. And this is very important, and inshallah in this course I will put the most important image and ask about and mention them. So this is the thyroglossal duct cyst, and of course as we mentioned the previous thyroid follicular cells derived from the endoderm, neural crest, pharyngeal pouch 4 or 5th. Parafollicular cells arise from the 4th pharyngeal pouch. Thyroid follicular cells from the endoderm. Parafollicular C cells from the neural crest or 4th pharyngeal pouch or 5th pharyngeal pouch. Thyroid examination, this is not very important actually, but in the clinical practice it is very important, and all of you know how to examine for the thyroid by inspection and palpation and percussion. And the most important auscultation and البروي constant with Graves' disease. This is very important. So a Graves' disease, a feature of a Graves' disease, exophthalmos, thyroid berui, and the pretibial myxedema like this. This is a pretibial myxedema. And actually pretibial myxedema is a pathognomic for Graves' disease. Once you see Graves dermopathy or pretibial myxedema or Graves ophthalmopathy or acropathy, this is a pathognomic for Graves' disease. الثيرويد berui, if present, this is suggestive of a Graves' disease, so put it in your mind. Once in the clinical scenario mentions that when the physician auscultates the thyroid, there is a berui, put in your mind, this is mostly Graves' disease. And actually in every exam or any scenario, you need to pick up some of alarming words, alarming points. This word can be a clue for the answer the question. And this is another image for pretibial myxedema, and don't forget that pretibial myxedema is a pathognomic for Graves' hyperthyroidism, not for hypothyroidism. Pretibial myxedema is a pathognomic feature for Graves' hyperthyroidism. What is your opinion about this image? And this actually is very important because in most of the exam, they will put this image in the exam. Actually, in the previous exam 2019, they put this picture. This is
Necrobiosis leopard.
which one?
Necrobiosis.
This is
Necrobiosis leopard.
necrobiosis lipidica, which is presented in type 1 or type 2 diabetes, controlled or not controlled type 1 or type 2 diabetes. This is very important because it may be mistaken as a pretibial myxedema. This is the pretibial myxedema actually, and this is the 3 images necrobiosis lipidica. And actually in our previous exam, they put this image. So it is very important in when you preparing for the
नहीं
exam.
परहेज करना फिर वो कहते हैं सिलिकॉन के पैड रखिएगा उसके.
Please, I hope from everyone, if not in interactive discussion, to mute his phone. Okay. So it is very important to collect the images to study them well before the exam. This is a pretibial myxedema, and we will discuss it in the next session, inshallah, the next Friday, when we discuss thyrotoxicosis and Graves' disease. And this is for necrobiosis lipidica, which we'll discuss in the diabetes chapter. And this also necrobiosis lipidica. And examination of the thyroid, this is from Davis, which is not very important to palpate, auscultate, and auscultation is very important, percussion, and consider systemic signs of thyroid dysfunction like tremor, pulmonary edema, warm peripheral tachycardia, lead lag, which is not pathognomonic for Graves' disease. Lead lag, don't forget that lead lag may be present in any case of thyrotoxicosis. A normal regulation of thyroid hormone is very important actually. الhypothalamus will secrete TRH, which is TSH receptor, thyrotropin releasing hormone, which stimulates anti-pituitary gland to secrete TSH. TSH will stimulate the thyroid gland in the presence of thyroglobulin, which acts as a performing matrix containing thyrosyl group, to which the reactive iodine attached to form the hydroxyl residue of monoiodotyrosine and diiodotyrosine. So thyroglobulin is essential in the presence of sufficient amount of the iodine. The iodine is the most important element, the biosensitive thyroid hormone, and actually in the exam they ask about a daily requirement of the iodine according to the WHO, and we will discuss it later, to form mainly T4, which is levothyroxine, and to a little extent triiodothyronine, which is T3. So thyroid gland secrete mainly T4 in about 80%, and in about 20 or 15% T3. But most of active hormone, which is T3, is as a result of conversion of T4 in the peripheral tissue by the iodinase enzyme, which is very important in the exam actually. And T4 and the T3 with a negative feedback mechanism affect the hypothalamus and the anterior pituitary gland to decrease the TRH and the TSH. And actually the iodinase is very important enzyme because it's responsible for conversion of T4 and T3 to T3 and reverse T3.
Let's begin with how the cells of the thyroid gland take up iodide from the plasma. It starts with the transport of iodide ions from the plasma into the follicular cells across the basolateral membrane.
Is the voice of this video present for everyone?
Yes, clear.
Okay. This is very important because this video demonstrates the synthesis and formation of thyroid hormone, and this is very important actually to understand the basic knowledge of this.
Via the sodium iodide cotransporter, which uses the sodium electrochemical potential to drive the transport of one iodide ion and two sodium ions. Once inside the cell, The extra sodium ions are transported back out of the cell via the sodium-potassium ATPase, while the iodide ion is transported across the apical membrane into the colloid space via the pendrin cotransporter. Pendrin transports one iodide ion into the colloid space in exchange for one chloride. However, the precise stoichiometry remains unclear. Once inside the colloid space, the enzyme thyroperoxidase oxidizes two iodide ions to form one iodine molecule. Next, the
So this is very important. A thyroid peroxidase enzyme is responsible for iodination. So any drug that inhibits TPO will affect iodination. Carbimazole and the propylthyracil, mesimazole, this antithyroid drug will inhibit thyroid peroxidase enzyme. And this actually in every exam they will ask about the mechanism of action of some drugs, and actually they usually ask about the mechanism of action of carbimazole or propylthyracil or mesimazole. They inhibit a thyroid peroxidase enzyme, which is responsible for iodination, and this is very important.
Oxidase iodinates the tyrosyl residues of the thyroglobulin protein. Iodinating a single tyrosyl residue forms monoiodotyrosine, while iodinating two tyrosyl residues forms diiodotyrosine. Iodination of tyrosyl residues causes the thyroperoxidase to conjugate neighboring tyrosyl residues.
This is a conjugation. This is a joining to form T4 and T3, which is need TPO. This is the coupling. Coupling need TPO. So the antithyroid drug will inhibit coupling. This is very important because it inhibits TPO. So carbimazole, propylthyracil, mesimazole inhibit iodination, inhibit coupling by inhibition of thyroid peroxidase enzyme. And this actually is one of the most important questions in the exam.
While iodinating two tyrosyl residues forms diiodotyrosine. Iodination of tyrosyl residues causes the thyroperoxidase to conjugate neighboring tyrosyl residues. This is important to note because it results in three different types: T4, T3, and RT3. RT3 is biologically inactive. The thyroglobulin protein involved in this process was initially synthesized in the endoplasmic reticulum of the follicular cells.
And this is very important. So thyroglobulin is formed in the endothelium reticulum. This is very important.
And secreted into the colloid space via exocytosis. Following the iodination and conjugation, the iodinated thyroglobulin binds megalin, which is an endocytic receptor located in the apical membrane of follicular cells. Binding megalin promotes the endocytosis of the iodinated thyroglobulin, after which lysosomes containing proteases fuse to the thyroglobulin-containing vesicle. The proteases then cleave the peptide bonds that flank where the T4, T3, or RT3 are located on the peptide backbone of the thyroglobulin. Once cleaved, T4 and T3 are transported out of the cell across the basolateral membrane via the monocarboxylate transporter.
Don't forget that monocarboxylate transporter 8 is very important because its deficiency will lead to a very important syndrome, which is MCT8 deficiency syndrome, and we will discuss it in more details later.
Once secreted into the plasma, 70% of the T3 and T4 are bound to thyroxine-binding globulin. Slightly less than 15% of the T3 and T4 are bound to thyroxine-binding prealbumin. 15% is bound to albumin. 0.03% of the T4 is unbound or free, while 0.3% of the T3 is unbound or free. Now, thyroxine-binding globulin is synthesized and secreted from the liver. It buffers the thyroid hormone, which helps normalize the plasma concentration and prolong the half-lives of T3 and T4. T4 and T3 are taken up by cells via the monocarboxylate transporter. Inside these cells, T4 is converted to T3 by the deiodinases. Next, T3 binds the nuclear receptor, which promotes the translocation of T3 into the nucleus.
So this is very important. Thyroid hormone receptor is present intranuclear. This is very important. So a thyroid hormone receptor is a nuclear receptor.
Talk more about the role of T3 in the micro lesson titled Thyroid Hormone.
So this is very important animation for this video. So the physiology mainly biosensitive thyroid hormone require iodine as a substrate, and actually as a video mentioned, sodium iodide symporter is very important to introduce iodide into thyroid follicle, and the thyroid peroxidase is very important in synthesis and formation of thyroid hormone. The thyroid is only the source of the T4. Thyroid secretes about 25% of circulating T3. T3 is the active thyroid hormone, and the conversion of T4 to T3 is very important because it is converted by the iodinase enzyme. Actually, in the previous exam, 2018 here, they asked about the enzyme responsible for conversion of T4 to T3, which is the iodinase type 1, which is present mainly in the liver and the kidney. This is very important. Another very important topic you need to know, and this I will mention this video. This is very important. This is the monocarboxylated transporter 8, which permit the passage of T3 intracellular, and another transporter responsible for entrance of T4 intracellular. T4 is converted to T3 by two very important deiodinase enzyme, D1 and D2, and of course D3 is inactivated by the deiodinase enzyme type 3 to T2, and this is very important. Active hormone with which T3 is enter the nuclear to bind to the thyroid hormone receptor, and then to form what is known as TRE, which is sensitized messenger RNA to form specific proteins. This is very important, and this will be discussed in more details a lot of times later. So we need to know that sensitive thyroid hormone can be inhibited by a variety of agents termed goitrogens. Goitrogens like cauliflower, like cabbage, like broccoli, and millet, and so on. And what is the most important? A lot of medications can inhibit thyroid hormone synthesis, and this actually in every exam they will ask question about this. For example, in the previous year, they asked about the mechanism of perchlorate and thiocyanate in the thyroid hormone inhibition. They inhibit iodide transport. Don't forget that perchlorate and the thiocyanate inhibit iodide transport. Thiourea, which is carbimazole and propylthiouracil and mesimazole, inhibit oxidation, inhibit coupling, has no role in thyroid hormone release, because in a previous exam they ask about the mechanism of action of carbimazole, and one option is thyroid hormone release inhibition. Carbimazole has no role in thyroid hormone inhibition. It inhibits TPO mainly, that responsible for oxidation and coupling of iodothyronine. In large doses, iodine itself block organic binding and coupling reaction, and this will be discussed in the next presentation when we discuss thyrotoxicosis. Lithium has a several inhibitory effects on the intrathyroidal iodine metabolism. So lithium inhibits intrathyroidal iodine metabolism, so will lead to decreased thyroid hormone formation, and lithium can cause hypothyroidism, and this is very important. Because in any case scenario, if they mention that the patient had a bipolar disorder, so you must say think in your mind that he may be use a lithium that may cause hypothyroidism. Actually, lithium can cause hyperthyroidism, but most cases cause hypothyroidism. Lithium can cause hyperthyroidism to a little extent, little percentage. In most cases, cause hypothyroidism. The same for amiodarone. Amiodarone can cause hypothyroidism, but in most cases cause thyrotoxicosis, and this is very important. So the most important to know that الكربيمازول and البروبايل inhibit الTPO, البيركلوريت inhibit الايودايد transport, الليثيوم inhibit الانتراتhyroidal iodine metabolism, and this actually is very important. This algorithm is updated in the 4th edition, and this is the same as the previous one. So الTPO inhibit الاوكسيدation, TPO الايودينيشن needs thyroglobulin, الTPO inhibit الTPO required for coupling, so الكربيمازول will inhibit the coupling and oxidation and so formation. And of course the propylcyracil has another unique mechanism, and we will discuss it later because it inhibits the iodinase enzyme type 1, so inhibit the conversion of T4 to T3. This is a unique for propylcyracil, not carbimazole, and so propylcyracil is used in the thyroid storm and have some advantage in this case. And this is another page from the medical physiology, the big picture medical physiology book, and this the same as previous one. They mentioned that iodide trapping is very important because iodide is transported intrafollicular cells by sodium iodide cotransporter or NIH to form iodide pool, which is moved to the thyroid colloid in the formation of thyroglobulin, which is formed in the endoplasmic reticulum, sensitizes the follicular cells by in the presence of thyroid peroxidase. Thyroid peroxidase oxidize iodide ion into iodine atom, and then the conjugation or joining together it det and the met to form T4 and T3, and after that the endocytosis of T4 and T3, and at the end exocytosis, which is a transform of thyroid hormone from the thyroid colloid intrathyroid follicle to the bloodstream. Most of them are T4 and a little amount of T3, which is T4 is converted to T3 by the iodinase type 1 and 2 in the peripheral tissue, which is very important. So this image is very important. Another important image, the same as previously. This is the same. So but in this image, I mentioned that anti-thyroid medication inhibit this step, and inhibit this step. Iodide inhibit proteolysis, and also I mentioned that الاميودارون and some anti-thyroid drug only propylcyracil inhibit the conversion of T4 to T3 in the peripheral tissue by inhibition of the iodinase type 1. And this value is very important because in our previous exam they ask about the daily requirement of the iodine in the adults. The WHO recommend a daily dose of iodine for adults 150 microgram per day. And this actually, this table from the Williams textbook of endocrinology, which is this is the 13th edition, and also we have 14th edition. But in both editions, they mentioned that recommended daily requirement for adults is 150, and irregular pregnancy is 200 microgram. But in our Oxford, the 4th edition, they mentioned that, and in the WHO, they recommend for a pregnant and lactating female, the daily requirement is 250 microgram per day. So in the exam, if they ask about the daily requirement of the iodine for a pregnant and lactating woman, please choose 250 microgram per day, not 200 as mentioned in the William textbook. So the daily requirement of iodine for adults and adolescents is 150, for pregnant and lactating female 250, for children is less than around 120 100 microgram per day. Iodine supplementation with potassium iodide need 150 microgram daily is recommended. Preconception and during pregnancy this is a supplementation, but actually the female require 250 microgram per day. but they recommend iodine supplementation with potassium iodide 150 microgram daily is recommended in preconception and during pregnancy, and this is from the Oxford, the 4th edition, not the 3rd edition. TBG is very important because, as mentioned in the previous algorithm, thyroid hormone, total thyroid hormone is almost inter-bound to the plasma protein. The most important one is thyroid binding globulin, TBG, which is formed in the liver. And another one is a trans-serotine TTR or prealbumin, and another one albumin. The most important is the TBG. And we should know that the T4 and the T3 bind to this proteins, the TBG, trans-serotine, and albumin to some extent a variable degree. A T3 is bound 10 to 20 times less avidly by TBG. So any factors that affect the TBG will affect the total thyroid hormone estimation. For example, in the female, in pregnant female, TBG will increase from the 7th week till the 16th week. The TBG will increase by 50%. So a total thyroid hormone normally will be increased during the pregnancy from the weeks 7 to the weeks 16 to be a plateau rise of the T4. From the 4th month of gestation, T4 will be increased by 1.5 the level as pre-pregnancy. This is very important because if you estimate total thyroid hormone during the pregnancy, during the 2nd or 3rd gestational age, you can diagnose it incorrectly as a thyrotoxicosis. But this is actually due to the increased TBG, which lead to false elevation of the total thyroid hormone. So we can depend on the free thyroid hormone, but actually free thyroid hormone has some pitfalls during the pregnancy. So the American Thyroid Association recommend estimation of total T4, and also the Endocrine Society for Management of Thyroid Disorder during pregnancy published in 2013. They mentioned that a total thyroid hormone is recommended measurement recommended during the pregnancy, but with adjustment for it according to the gestational age. So any conditions that affect TBG will affect the total thyroid hormone level, not free thyroid hormone. So, for example, if any female receiving estrogen therapy, which lead to increased TBG, this will lead to falsely increase of the total thyroid hormone. If you do a thyroid function test, you will find the T4 is elevated, the total T3 is elevated incorrectly. So you need to know this. Another very important one is the T4 and the T3 are metabolized in the liver by conjugation with glucuronate and sulfate. So there are a lot of enzymes inducer drugs like الفينوباربيتال, الكربامازابين, and الفينوتاين. So الفينوباربيتال, الكربامازابين, phenytoin, this is enzyme inducer, will increase the metabolic clearance of the hormone. Once increase in metabolic clearance of the hormone, this will lead to decrease in level of total thyroid hormone incorrectly. So enzyme inducer will lead to falsely low T4 and T3. So if you have a case scenario and the patient already on phenobarbital or carbamazepine and phenytoin, you must think that a total thyroid hormone will be falsely low. This is due to enzyme inducer. The opposite with enzyme inhibitor, which can lead to increase total thyroid hormone. Enzyme inducer, if you need what is the enzyme inducer, you can know the BC+. BC+, this is the mnemonic for it. B for phenytoin, C carbamazepine, B barbiturates, or rifampicin, A alcohol, is sulfonylurea. So these drugs can lead to decrease of total thyroid hormone incorrectly. This is enzyme inducer. So enzyme inducer, which is BC+, 10 minutes and Zoom session will be ended and we will rejoin again. So enzyme inducers such as phenobarbital, carbamazepine, and phenytoin will lead to increase in metabolic clearance of hormone without decrease the free thyroid hormone. This is very important actually. In our previous exams, they ask about T4 and T3 are secreted in a ratio of about. And they in the exam they mentioned a lot of ratios. You must know that T4 and T3 are secreted in a ratio of about 15 to 1. 15 to 1. This is a very important because in our exam they ask question about this ratio. So a ratio of T4 to T3 are secreted in a ratio of about 15 to 1, and actually this image from the Oxford Desk Reference Endocrinology not presented in the Oxford Handbook. Actually, this is the only question is not available in the Oxford Handbook of Endocrinology and Diabetes, either fourth or third edition. And actually, in the latest edition of the William textbook, they mentioned that the fact that the ratio of T4 to T3 in the human thyroglobulin is 15 to 1. But actually, they mentioned that the molar ratio of T4 to T3 in the thyroid secretion is approximately 10 to 1. So you need to know this number. The molar ratio of T4 to T3 in the thyroid secretion is approximately 10 to 1, but the ratio of T4 to T3 in the human thyroglobulin is 15 to 1. So you need to memorize these numbers. And this is a disorder of thyroid hormone protein interaction. Of course, if the TPG is increased for any reason, the total thyroid hormone will be increased incorrectly, but the free thyroid hormone will be normal. If the TPG is decreased due to any cause, the total thyroid hormone will be decreased and the free thyroid hormone will be normal. But in the case of hyperthyroidism, both of total thyroid hormone and the free thyroid hormone will be increased, and in case of hypothyroidism, total thyroid hormone will be decreased with also the free thyroid hormone will be decreased, and this needs to more clarification, and we will mention it later on because thyroid hormone, either total and the free thyroid hormone, may be normal in a case of subclinical primary thyroid disorders actually, and this is a subclinical hyper or hypothyroidism. And the T3 has no rule for hypothyroidism. So this is another very important slide. Everyone needs to memorize it. What is the factors that lead to increased TPG and so leading to falsely increase of total thyroid hormone T4 and T3. Pregnancy is very important, and all conditions that affect all condition like pregnancy, oral contraceptive. So any condition leading to abnormality in the pregnancy can be occurred with oral contraceptive pills. So in the pregnancy, estrogen increase the same way if the patient receive oral contraceptive pills. Both conditions leading to increase TPG and increase of the total thyroid hormone. Also, tamoxifen, this is very important because it is a previous question. Tamoxifen leading to increase TPG. Don't forget this. A chronic active hepatitis A lead to increased TPG. Biliary cirrhosis leading to increased TPG, but a chronic liver disease will lead to decreased TPG. So, a chronic active hepatitis A, biliary cirrhosis leading to increased TPG. Acute intermittent porphyria leading to increased TPG. Another very important condition that leading to decreased TPG is androgen. Androgens, a large dose of glucocorticoid, and the same as Cushing, because Cushing is endogenous. Cushing is a corticosteroid excess, so the both condition lead to decreased TPG and lead to falsely low T3 and T4. A chronic liver disease because TPG is sensitized in the liver. A severe systemic illness lead to decreased TPG. Acromegaly, nephrotic syndrome, and any condition leading to losing protein like losing enteropathy or nephrotic syndrome will lead to decreased TPG, and so T3 and T4 will be decreased incorrectly. Don't forget phenytoin, which is BC-PRAS, which is enzyme inducer. BC-PRAS, a drug phenytoin, lead to decreased TPG, leading to decrease T4 and T3. This is a very important slide actually in the exam and for answering some question. So this is another question. Which of the following is thyroid hormone receptor? I want someone to answer this question.
Nuclear receptor.
Yes, this is a nuclear receptor as mentioned previously. Thyroid hormone receptor is a nuclear receptor. What about the TSH receptor? Because another question we need to know. So try to collect the similar conditions and write a notes in your book. So a thyroid hormone receptor is a nuclear receptor, but TSH receptor is
Cytoplasmic.
it is a transmembrane. A transmembrane. A transmembrane G protein receptor. So a TSH is a transmembrane. And actually this okay. So what we know, we need to know about the molecular aspect of thyroid hormone. The thyroid hormone receptor is a cell nuclear receptor, and there are two types of thyroid hormone receptor. Thyroid hormone receptor alpha and beta, and this is actually it's very important in some of genetic disorders, and we will discuss later. And actually, this is can be clarified more and more by one of the presentation I previously gave, and I will give the link later on. And one of the very important topic is الأيودوثيونين dehydrogenase enzyme. We have three dehydrogenase enzyme, D1, D2, D3. Each one has some site of prevalence in some tissues. For example, a D1 enzyme mainly presented in the liver and the kidney, and this is very important because this is a previous exam question. Another dehydrogenase enzyme 2, which is present mainly in the pituitary and the neuron, and D3, which is present mainly in the placenta and another tissue. This is a very important topic actually. Don't forget, if you need to know one slide, please try to study the dehydrogenase enzyme. Actually, it's the same algorithm that T4 and T3 is enter the cell via MCT8 co-transporter and another co-transporter, and the T4 is transformed to T3 by 5 dash. Don't forget that dehydrogenase had another name which is 5 dash dehydrogenase enzyme, because some previous question asked about 3 dash dehydrogenase. Dehydrogenase enzyme is 5 dash dehydrogenase enzyme. 1, 2, 3. So T4 is converted to 2, 3 by dehydrogenase type 1 and 2, and the T3, which is active hormone, is pass through into nucleus to join to the thyroid hormone receptor, which is alpha and beta, and each one has a specific subtypes, alpha 1 and alpha 2 and beta 1 and beta 2 and so on, to transcript messenger RNA to form some of protein. And also T4 is converted to the reverse T3, and T3 is converted to the T2 by dehydrogenase type 3. This is very important. So this image is very important because a lot of questions in the exam ask about this. For example, in the 2017 question, they ask about enzyme responsible for hepatic conversion of T4 to T3. So this is dehydrogenase type 1. Dehydrogenase type 1, which is present mainly in the liver and the kidney, they ask about an enzyme responsible for conversion of hepatic conversion of T4 to T3. So it is D1. D1 is responsible for conversion of T4 to T3. This is the main action of dehydrogenase enzyme type 1. This lead to increase of T3. Dehydrogenase type 2 is responsible for conversion of T4 to T3, but mainly in the brain, in the pituitary, in the neuron. So may ask about enzyme, dehydrogenase enzyme responsible for conversion of T4 to T3, D1 and D2. So this slide is very important for all of us. So I will go to, so the deiodinase enzyme type 1 and type 2 is responsible for conversion of levothyroxine T4 to T3. But D1 responsible for this conversion in the liver and the kidney, and D2 is responsible for conversion in the brain, pituitary, and the neuron. This is very important because previously they asked about enzyme responsible for hepatic conversion of T4 to T3. This is the deiodinase type 1. And another question in the toolbook asked about responsible for conversion of T4 to T3 in the neurons. This is the D2. And actually, the deiodinase type 3 is responsible for conversion of T4 to reverse T3, inactivated T4, and responsible for conversion of T3 to inactive hormone T2. And this is mainly present in the placenta and to some extent in the brain and the fetal tissue. And this actually is responsible for degradation of thyroxine. The thyroxine of the mother, pregnant female, will be degraded in the placenta by the deiodinase enzyme type 3, which convert T4 to reverse T3. And this is very important. So in the exam, they will ask a lot of questions about this slide. Also, for example, in the previous exam, they ask about the propylthyracine, which inhibit which deiodinase enzyme. The propylthyracine inhibit deiodinase type 1 in the peripheral tissue, so has advantage over the carbimazole. So it inhibit the conversion of T4 to T3 in the peripheral tissue, and this is very important in the management of thyrotoxic storm. So the propylthyracine inhibit D1, D3 in the placenta, D2 in the neuron, D1 in the liver and the kidney. D1 and D2 conversion of T4 to T3, D3 conversion of T4 to reverse T3, conversion of T3 to the T2. This is very important slide actually. And in our previous two exams, they ask about the enzyme responsible for conversion of T4 to reverse T3. Which one? T4 to reverse T3?
D3.
D1, D what?
D3.
D3. So T4 is converted to reverse T3 mainly by D3, but actually D1 can convert T4 to reverse T3, but to a lesser extent. The main function of D1 is convert T4 to T3. Conversion of T4 to reverse T3 actually occur with D1, but to a little extent. The main function of D3 is conversion of T4 to reverse T3. So I want from all of you to remember the large arrows only, which is very important. And also they ask another question in 2020 about the deiodinase 1, which is present mainly in the liver. So in the 2020 exam, they ask two questions about the deiodinase. One, for the presence of deiodinase type D1 in which tissue, liver, kidney. This is the main organ. And ask another question about the mechanism of action of propylthyracine that inhibit deiodinase type 1. This is very important question. So a deiodinase enzyme is very important, and this is very important. The same table actually from the Atoll second edition book, they mentioned that. Don't forget that the deiodinase enzyme is 5' deiodinase enzyme, not 3'. 5' deiodinase enzyme. There are outer ring and inner ring. If forget these names, outer ring and inner ring, but it is if you need to know it, outer ring of the T4 result in the formation of biologically active T4, so it is present mainly in D1 and D2. This is the outer ring, and inner ring lead to formation of metabolic inert reverse T3, so it is mainly present in the type 3 and type 1, because as we mentioned previously, T4 is converted to reverse to T3 by the deiodinase type 1 to a lesser extent. So type 1 is present mainly in the liver, muscle and kidney. Type 2 is mainly present in the neuron and the skeletal muscle. Type 3 mainly present in the placenta. Don't forget that in a type 3 protect the placenta from excess T3 and T4. If the mother receives T4 to a huge amount, the agonist enzyme type T3 will protect the fetus from this excess thyroxine. Another very important in type 1 is increased in hyperthyroidism. So this dehydrogenase enzyme activity will increase in hyperthyroidism. So you must remember that in hyperthyroidism, T4 will convert it more and more to T3. Okay, this what will occur after this conversion? The percentage ratio of T3 will be more and more than T4. Why this occur? Because the adenase enzyme type 1, D1, in the hyperthyroidism will increase more and more in its activity, which lead to more conversion of T4 to T3. So, the American guidelines, in the latest guidelines for management of thyrotoxicosis, hyperthyroidism, and other causes of thyrotoxicosis, mentions that the ratio of total T3 to total T4 can be useful in assessing the etiology of thyrotoxicosis. T3 will be elevated above the upper limit of the normal more than T4 in the thyrotoxicosis caused by endogenous hyperthyroidism. So in case of Graves' disease, if we have two patients, both of patients have thyrotoxicosis. One, for example, due to the toxic nodule, another one for destructive thyroiditis, for example. In the endogenous thyrotoxicosis, T3 to 4 ratio will be increased more and more. So in this guidelines, they mentioned that T4 is elevated more than T3 in thyrotoxicosis caused by thyroiditis. Why? Because in the in Graves' disease, in hyperthyroidism, diatonase type 1 will be increased in hyperthyroidism, which lead to the conversion of T4 to T3 more and more, leading to increasing percentage ratio of T3 to T4. And actually in the guidelines, they mentioned another very important in clinical practice, T3 to total T4 more than 20 by reference nanogram per, and microgram in Graves' disease and toxic nodular goiter, and less than 20 in ALS or postpartum thyroiditis. So the T3 to 4 ratio will be increased in the toxic nodular goiter or endogenous hyperthyroidism, and will be decreased in the ALS and postpartum thyroiditis. And this can be a clue for differentiation between postpartum thyroiditis and endogenous Graves' disease postpartum. This is very important clinically. But this ratio is not very important actually in the exam. Thyroid hormone, is, as we mentioned, that the function of thyroid. Yes?
Like in the guideline, why propylthiouracil is not the first line? Because in hyperthyroidism, D1 is increased and PTU can inhibit the D1. So PTU should be the first line therapy even in non-pregnant people.
Yes, actually, propylthiouracil side effects is more than carbimazole. Since a few years, several amount, and this will be discussed actually in the next presentation, because actually in every exam they will ask about granulocytosis and the side effects, and why we use carbimazole in most of our cases rather than propylthiouracil, because conditions actually. Carbimazole is more effective than propylthiouracil, and the carbimazole is more safe than propylthiouracil on the liver. Some cases, reported cases, liver cell failure from propylthiouracil. So all recommendation nowadays recommend propylthiouracil only in two conditions. In thyrotoxic storm, this is the first one, and another one is the first trimester, because propylthiouracil is more safe for the fetus in the first trimester. Propylthiouracil and carbimazole, both drugs are teratogenic. Both drugs can cause a teratogenic effect, but propylthiouracil is more safe in the first trimester on the fetus, And in the second and third trimester, both drugs are the same on the fetus, but carbimazole is more safe on the liver. So all recommendation recommend to use carbimazole because this is more safe on the liver. And actually in the exam they ask about an incidence of liver cell failure if the patient receive carbimazole or propylseracil. This is a very common question in the exam. And the side effect of antithyroid drug is very important in all exams actually, and this will be discussed later inshallah in the next presentation. So it is very important to know this. So the only recommendation for using propylseracil is in the first trimester and in the thyrotoxic storm. Since a few years, we recommend the propylseracil during the pregnancy, first and second and third trimester, and during lactation and for elderly and for young children. But nowadays, it is the only situation that all the recommended guidelines recommended propylseracil first trimester and thyrotoxic crisis. And if there is some reaction from carbimazole, we can try propylseracil. Some skin reaction, some allergy, not a granulocytosis, because if a granulocytosis occur with carbimazole, you cannot use propylseracil in this situation. But if there is a skin allergy, severe skin allergy with carbimazole, we can try to use propylseracil in this condition and can give antihistaminic drug. This actually will be discussed later in the next presentation, inshallah. So don't forget that the function of thyroid peroxidase enzyme include oxidation, organification, and coupling. Yes, actually, this will be discussed. Actually, Dr. Khalid Wafig asked about what about the hyperthyroidism woman preparing for a pregnancy. Should we use propylseracil or carbimazole? Actually, most of the guidelines recommend the propylseracil, and we will discuss it later, inshallah, in the next presentation. Because in the Oxford Handbook, they mentioned that if the mother preparing for pregnancy, we need to convert it to give to propylseracil. And actually, there are a new paragraph in the fourth edition, very important, will be discussed later, inshallah, in the next presentation. So, propylseracil and mesimazole or carbimazole. Mesimazole, this is the active metabolite of carbimazole, inhibit oxidation, organification, coupling, inhibit thyroid peroxidase. Don't forget that we have what is known as Wolff-Chaikoff effect. Wolff-Chaikoff, off. So turn off thyroid peroxidase. So Wolff-Chaikoff off leading to hypothyroidism. This is very important. Don't forget that Wolff-Chaikoff effect leading to hypothyroidism. And this is protective autoregulation, which means sudden exposure to excess iodine, temporary turn off thyroid peroxidase, leading to decrease the production of thyroid hormone T3 and T4. The free thyroid hormone, the active hormone is free T3, which binds to the nuclear receptor. And the main function of the T3 mainly 7 B's: brain maturation, point growth, beta adrenergic effect, basal metabolic rate, increasing basal metabolic rate, increase the blood glucose, leading to increased glycogenolysis and gluconeogenesis, and the breakdown of the lipids, and stimulate surfactant synthesis in babies. So this is the summary of the function of thyroid hormone from another book. So this is the Wolff-Chaikoff effect, which leading to iodine-induced hypothyroidism. And don't forget that Jod-Basedow effect leading to iodine-induced hyperthyroidism. So Wolff-Chaikoff effect hypothyroidism, Jod-Basedow effect hyperthyroidism in normal thyroid tissue. Wolff-Chaikoff effect can occur in the normal thyroid tissue and can occur in the underlying Graves' disease. But Jod-Basedow effect, which causes iodine-induced hyperthyroidism, this occurs only in abnormal thyroid. الثيرويد هرمون enhance the following: enhance the age sensitivity, enhance the myocardial oxygen consumption, enhance the nerve conduction, gluconeogenesis, and oxidation of the fatty acids. Because there are some questions asked about the function of thyroid hormone. They increase insulin sensitivity. This is very important in the previous question. And actually, a regulation, hypothalamic pituitary thyroid axis, actually, we give it previously, but this image, I want everyone to know this. Hypothalamus secreted TRH, which is stimulated anterior pituitary gland to secrete TSH. A lot of factors can inhibit the anterior pituitary gland and so on, inhibit the TSH level. This is three drugs, very common three drugs: somatostatin, dopamine, glucocorticoid. So in every patient with a high dose of glucocorticoid or dopamine, any patient in ICU, don't forget the patient may be on dopamine, which can lead to decrease the TSH level incorrectly. So if the patient on dopamine, glucocorticoid, suspect that TSH will be falsely low. This is drug inhibit the anterior pituitary gland to decrease the TSH. So this drug can be used in the management of TSHoma. TSH secreting pituitary adenoma, we use mainly somatostatin and some sort of dopamine agonist. Also, this is very important. Also, this is another image. This actually, I repeat it a lot of times in sense of thyroid hormone, but I mentioned here that propylthyracil and mesimazole inhibit thyroid peroxidase, which is responsible for oxidation, organification, and coupling. This is very important. And don't forget, a release of thyroid hormone, propylthyracil and mesimazole has no role in the thyroid hormone release. And the peripheral tissue propylthyracil inhibit the 5-dehydrogenase enzyme type 1, which is responsible for conversion of T4 to T3 in which organ? Liver and kidney.
Kidney, liver and kidney.
Yes, this is very important. So dehydrogenase enzyme type 1 present mainly in the liver and kidney. Type 2 present in
Brain.
brain and neuron. This is very important. Type 3
Placenta.
placenta. Type 3 responsible for conversion of T4 to
Reverse T3.
reverse T3. This is very important. And type 1 responsible for conversion of T4 to
T3.
T3 mainly, and also responsible for conversion of T4 to minimal amount of reverse T3, but this is a slow or minimal effect. If you ask about responsible for conversion of T4 to reverse T3, this is a dehydrogenase type 3.
T1.
T4 to reverse T3, D3. But T4 to T3, T1. And this is very important, and actually I repeat it a lot of times because this is very important in the exam. So anyone can print one of these images and study it more and more and put his remarks, and I hope everyone to write his own notes in his book. Like this, I will show like this is my book. For example, I put this actually in the green. I can remove it. I will send image to save time. So everyone can write his own notes in the book. And this is abnormal development of the thyroid gland in lingual thyroid, thyroglossal cyst, which needs surgical removal. This is a recommendation. And another very important topic, which is the test for homeostatic control. Don't forget that TSH is the first line diagnosis of a primary thyroid disorder. A primary thyroid disorder, if TSH is normal, this excludes the primary thyroid disorder. According to the all guidelines, a single best screen test for primary thyroid disorder is TSH. But in the secondary thyroid disorder, TSH has low value. We should do TSH with thyroid hormone to diagnose central thyroid disorder, either hyperthyroidism or hypothyroidism. Another test that is not used nowadays, which is TRH stimulation test. This test actually is rarely used nowadays. As we mentioned previously in this algorithm, I will show this. TRH responsible for what? Increase stimulated pituitary gland to secrete TSH. So in everyone, if we inject TRH, what is you expect? TSH will be increased. This is a normal
Increase.
physiological response. This is a normal physiological response. So if the hypothalamus, if the anterior pituitary gland is intact, and we inject TRH and estimated TSH, we will find that TSH will be elevated. This is a normal response. But this test is very helpful for differentiation between resistant to thyroid hormone TRH versus TSH secreting adenoma, and this actually is very important topic in the exam. So TRH stimulation test is used to differentiate between resistance to thyroid hormone, in which if we inject TRH, a TSH will be raised more than 5 fourths as normal. But in a case of TSHoma, TSH secreting pituitary adenoma, if we inject TRH, in this situation, TSH will not be increased, which is called a blunted response. So if we inject TRH in the normal personnel or in the resistance to thyroid hormone case, in this case, TSH will be increased more than 5 folds. In TSH home, if we inject TRH, TSH will not be increased,
Not increase.
just mild increase, about 1.5 increase, and this will be discussed later when we discuss resistance to thyroid hormone, and also we will discuss it in another two situations, one of them in the thyrotoxicosis, central thyrotoxicosis, and another one in the pituitary chapter. So this is very important test. Okay. So normally someone asked to repeat this point. Normally, if we inject TRH by a specific protocol for a normal person, TRH will stimulate the anterior pituitary gland, which is intact in the normal personnel. In this situation, TSH will be increased by more than 10 folds, 5 folds. So if we inject TRH, normally TSH will be increased. This is the normal condition. But in a case of TSH secreting pituitary adenoma, if we inject TRH, TSH will not be increased as normal. In a case of resistance to thyroid hormone, TSH will be increased if we inject TRH by specific protocol. So a TRH stimulation test, a blunt response diagnose, which one? TSH secreting pituitary adenoma.
TSH. Yes.
Secreting pituitary adenoma, TSH. Because in some exam, they ask in which condition a TRH stimulation test will be blunt response. This is a TSH TSH secreting pituitary adenoma, because in resistance to thyroid hormone, this is the same as normal individual. TSH will be increased more than 5 fourths, and this will be discussed today, inshallah, later. But actually, there are some conflicting points that TSH is misleading. As we mentioned previously, TSH is the good test for diagnosis of primary thyroid disorder. But in the hypothalamic pituitary disease, TSH can be misleading. In a recent treatment of thyrotoxicosis, in non-thyroidal illness, in a case of TSH assay interference, in a case of RTH resistance to thyroid hormone and disorder of thyroid hormone transport, in this condition, if you measure TSH alone, may be misleading. So the first one is hypothalamic pituitary disease, like central hypothyroidism. How we diagnose central hypothyroidism? Mainly Yes, Dr. Khalid Wafig asked if a patient with hypothyroidism, with a patient presented mainly by a clinical manifestation of hypothyroidism. Of course, TSH is the first one. If TSH normal in this condition, it excludes the primary thyroid disorder. So you don't need to do 3 to 4. But if you suspect it is a central hypothyroidism, in this condition, TSH alone can be misleading. So in this condition, if you suspect central hypothyroidism, you need to do 3 to 4 and TSH. 3 to 4 will be low. What about the TSH?
Low.
Low or low normal or normal or mildly
Normal.
elevated or mildly elevated. And this is a new information everyone should know about it. And when we will discuss ETA guidelines for central hypothyroidism, this is mentioned. Usually TSH in central hypothyroidism will be low normal, but in some cases TSH may be mild elevation. TSH about 6, 7, 8 with low T 3 to 4. T3 in central hypothyroidism has no rule. So how to differentiate between central hypothyroidism with mild elevation of TSH with overt primary hypothyroidism? In both conditions, TSH will be elevated with low 3 to 4. How to differentiate between them?
T3.
No, as we mentioned previously, T3 has no role for hypothyroidism, either diagnosis or follow up. This is actually
Sorry, what?
what?
Antibody.
Yes. Actually, a lot of conditions that may, for example, if some patient presented by these numbers, the T4 is mildly elevated, TSH is mildly elevated with low 3 to 4, and he said he do a pituitary surgery. So this is a central hypothyroidism. If he has a previous pituitary radiotherapy, this is a central hypothyroidism. If you do thyroid ultrasonography and the thyroid architecture is normal, so this is mostly suggestive of central hypothyroidism. If an RTTO, which is a pathognomic, not present in Hashimoto's thyroiditis in about 90-95%, so this is with a central hypothyroidism. So to differentiate between central hypothyroidism, which is presented by mild elevation of TSH with low 3 to 4, with primary hypothyroidism, by the history, by examination of the thyroid and thyroid autoantibody and thyroid ultrasonography and history of another condition. And actually, in most cases of overt hypothyroidism, if T4 is low, usually TSH more than 10. And actually, in the central hypothyroidism, TSH always not exceed 20. And this is very important. Another condition, TSH woman. What is the thyroid function test in the TSH woman?
Will be high.
What about thyroid hormone?
Increase T4 and non-suppressed TSH.
Yes, this is correct. So in the TSH woman, both T3 and T4 must be elevated, total or free. This is not our topic today. With non-suppressed TSH. Non-suppressed means what? TSH may be mildly low, 10 minutes running out for Zoom. So in TSH T3 and T4 will be elevated with non-suppressed TSH will be mildly low or normal, and this is very important. And another condition in which TSH may be misleading in the recent treatment of thyrotoxicosis, because suppression of TSH need a lot of time to recovery. Suppression of hypothalamic pituitary thyroid axis, suppression of this axis need several months to recovery. So in any patient of a grave disease, if you give antithyroid medication, how to follow this patient? By thyroid hormone, not by TSH. TSH will be low and suppressed for several months. So we follow this patient by thyroid hormone alone. This is very important. Another condition, TSH is misleading in non-thyroidal illness syndrome because TSH may be low, T3, T4 may be low. This is a low T3 syndrome. And another one is TSH interference because interference. For example, if the patient receives biotin, TSH will be falsely low. In macro TSH and a heterophil antibody, TSH will be mildly elevated, falsely elevated. And this assay interference is very important. And actually, in the latest Thyroid Egypt, I gave a presentation about thyroid hormone assay interference. And another very important condition, resistant thyroid hormone and disorder of thyroid hormone transport or metabolism. In the resistant thyroid hormone, what is the thyroid hormone value? Thyroid function test.
TSH high,
TSH will be
elevated.
mainly in the resistant to thyroid hormone will be elevated with non-suppressed TSH. In normal physiological condition, if the thyroid hormone is elevated for any condition, physiological condition, TSH will be suppressed. If this condition is not occurred, this is termed as non-importance of TSH. Non-suppressed TSH. So in resistant thyroid hormone will be elevated, both T3 and T4 will be elevated with inappropriately low or low normal TSH. No. A resistant thyroid hormone TSH will be mildly elevated or normal. And resistant to thyroid hormone will be elevated with normal or elevated TSH. This is TSH like TSH2. So we need to differentiate between TSH and resistant to thyroid hormone because both conditions the same thyroid function test. Thyroid hormone is elevated, T3 and T4 with non-suppressed TSH. Okay. Dr. Iman El Jamal asked for a break for 5 minutes. Actually, so we can take 5 minutes break, but not now, Dr. Iman. Just after 10 minutes when Zoom session closed by the program. Okay.
Dr. Khalid, TSH-OMA is tumors creating TSH causing increased thyroid hormones.
Yes, it is a trauma. What?
So in TSH-OMA, TSH levels will be suppressed because of negative feedback.
Not suppressed. In TSH-OMA and resistant thyroid hormone, thyroid hormone will be increased with non-suppressed TSH. So TSH will be normal.
TSH levels will be high.
Normal or high. Normal or mildly elevated. And this is very important topic and we will discuss it later, inshallah.
Oh.
Actually, I have a lot of slides, so I will try to rapidly go. Someone have some noise, please. I will mute. So this is a thyroid hormone concentration and various thyroid abnormality. In primary hyperthyroidism, TSH will undetectable or suppressed with elevation of both thyroid hormone. T3 thyrotoxicosis, TSH undetectable, normal T4 with elevated T3. This is very important. A subclinical thyroid disorder, a subclinical hyperthyroidism, TSH is low with normal thyroid hormone. A second hyperthyroidism, TSH-OMA, TSH will be normal or elevated with elevated both thyroid hormone. Thyroid hormone resistance the same as TSH-OMA. Primary hypothyroidism, TSH will elevated with low free T4. This is not correct. Don't depend on free T3 or total T3 in the hypothyroidism, primary hypothyroidism. Subclinical hypothyroidism, TSH is elevated with normal thyroid hormone. Secondary hypothyroidism or central hypothyroidism, T3, T4 mainly free T4 is low with low or normal TSH. So if you see a thyrotoxic patient with suppressed TSH with normal free T4, can we diagnose it as subclinical hyperthyroidism? Actually, no. We should do total and free T3 to exclude T3 thyrotoxicosis. And this is very important because T3 toxicosis should be considered in any patient with symptom, but normally free T4 with suppressed TSH, because T3 toxicosis, this is the only Graves, maybe an early manifestation of Graves disease. So subclinical hyperthyroidism, this is very important. TSH with low with normal thyroid hormone, and we should repeat it again within 2 to 3 months to diagnose it as a persistent subclinical hyperthyroidism, and we can classify it according to the TSH to grade 1, in which TSH is 0.1 to 0.4, and the grade 2, which is severe subclinical hyperthyroidism, in which TSH is less than 0.1, and we can manage it, the patient with subclinical hyperthyroidism, according to the grade of subclinical hyperthyroidism. This is very important actually, and we will discuss it in the subclinical topic. Another one is subclinical hypothyroidism, TSH is elevated with normal T4. And also the guideline recommend to repeat measurement within 2 to 3 months to diagnose it at subclinical hypothyroidism. And in this situation, we should do anti-TPO at the same session. Drugs that affect the thyroid test, this is very important, as we mentioned previously. Glucocorticoid, dopamine agonist, phenytoin, dopamine, octreotide, paroxetine can lead to decrease TSH secretion. Amiodarone, and this is very important, will lead to transient elevation of the TSH if in the recent administration of amiodarone. Another drugs like sertraline and citrate can increase TSH abnormally. And another drug, the lithium and amiodarone, interferon alpha, lead to decrease T3 and T4. Glucocorticoid, phenytoin, carbamazepine affect the binding protein and leading to decrease the binding protein, and so lead to decrease T3 and T4. And also salicylate can lead to decrease the binding T4, T3 binding the serum. What is the most important to know today? Carbamazepine, phenytoin, non-steroidal, leading to low normal free T4 and the free T3 with normal TSH, which is mimic to the central hypothyroidism. Heparin lead to elevation of the free thyroid hormone with normal TSH, with mimic TSH as resistant to thyroid hormone. So in any patient receive heparin, you must suspect that the free thyroid hormone is elevated incorrectly. In any patient who is receiving carbamazepine, phenytoin, non-steroidal, free T4 and T3 will be low incorrectly. This is very important in the exam. So if you see a hospitalized, in a case scenario, hospitalized patient, you must suspect the patient, if he received low molecular weight heparin, the free thyroid hormone will be elevated incorrectly. If the patient on anti-carbamazepine or phenytoin, the patient, you suspect that T3 and T4 will be falsely low with normal TSH. A typical thyroid function, I think the program said that we have less than 1 minute, so I think, as mentioned by Dr. Iman, we will take only 5 minutes as a break, and I will continue this session after 5 minutes. So after 5 minutes, I will join again to this session. Thanks for all. So this is a very important one, a typical thyroid function test. When we see suppressed TSH with normal free T4, as we mentioned previously, we should suspect T3 thyrotoxicosis before diagnosis of subclinical hyperthyroidism. If TSH is low or suppressed with normal free T4 and free T3, this is maybe subclinical hyperthyroidism, maybe recovery from thyrotoxicosis, maybe excess thyroxine replacement, and maybe non-thyroidal illness, which is known as low T3 syndrome. If elevation of the free T4 and T3, both hormones are elevated with non-suppressed TSH, This is maybe TSH secreting pituitary tumor, maybe thyroid hormone resistance, maybe heterophile antibody. And heterophile antibody actually mainly presented by elevation of the TSH mainly, and in some conditions elevation of the free T4 and T3 according to the cat, leading to spurious measurement of free T4 and T3, and in most cases TSH will be elevated. Thyroxine replacement therapy, the patient, if a patient receives thyroxine for any cause, iatrogenic abuse of thyroxine, TSH will be suppressed with elevation of the free thyroid hormone. Another condition with amiodarone, elevation of the free T4 and low normal free T3 with normal TSH. So there is a discrepancy between TSH with T4 and T3. T4 is elevated, T3 is low with normal TSH. You must suspect this is amiodarone or assay interference. Suppressed or normal TSH with low normal free T4 and free T3. This is a non-thyroidal illness or central hypothyroidism or isolated TSH deficiency. So this is a very important atypical thyroid function test. In the fourth edition of Oxford Handbook, they add a very important two sectors of patient. Biotin leading to increase of the free thyroid hormone with suppressed TSH, which is mimic hyperthyroidism. So if any patient on biotin therapy, for example healthy hair, you must suspect that the patient may be presented by suppressed TSH with elevation of the free thyroid hormone, which is the same as thyrotoxicosis. Another very important one is heparin, which affects free thyroid hormone, leading to elevation of the free thyroid hormone. And actually this table, this algorithm is very important, and this is extracted from the best and the practice and research journal in a paper known as a pitfall in the measurement of and the interpretation of the thyroid function test. And this mentions that for example, if TSH is elevated with normal thyroid hormone, this is maybe subclinical hypothyroidism or poor compliance of thyroxine, or malabsorption of thyroxine, or some drugs can cause this condition, or assay interference, or non-thyroidal illness recovery phase, or TSH resistance, and so on. So this is very important. Everyone can print this page and read it several times. So knowledge of hypothalamic pituitary thyroid axis physiology and a lot of factors, and knowing the different pattern of thyroid function test is essential to establishing the correct diagnosis, because in the exam they will mention abnormally or discordant thyroid function test and ask what is the diagnosis and how to manage, and you need to exclude the confounding and intercurrent illness or medication usage coupled with reassessment of thyroid status. This is the first step to resolve such cases, and you need to exclude the assay interference and also genetic and acquired disorder. This is the last step, because this is a very rare condition to identify a cause of discordant thyroid function test. So this is actually from the fourth edition of the Oxford Handbook. They mentioned that ingestion of 5 to 10 milligram of biotin, which is usually available as a multivitamin, result in spurious result in thyroid test, leading to falsely low of measured TSH, and actually leading to falsely elevation of T4 and T3 and TSH receptor antibody, which is a pathognomonic for Graves' disease. So if the patient on biotin, you will find that TSH is low, the free thyroid hormone is elevated, the free T3 hormone is elevated, therapy is positive, which is you go to a Graves' disease and give antithyroid drug and medication and so on. Actually, this is incorrect. If you see a multivitamin drug, if you see in a case scenario the patient on biotin, you must suspect assay interference with biotin, which is mimic a Graves' disease. How to differentiate? In a patient with biotin and presented by low TSH with elevated thyroid hormone, the patient usually asymptomatic, no symptoms of Graves' disease. But if you see Graves or batopathy or dermopathy or a manifestation of a Graves' disease, so you must suspect it is a Graves' disease. But if in history is a patient on biotin, you must stop biotin for at least 2 days and reassess thyroid function test. And actually, this I give it in a very important presentation about when thyroid labs lie. And actually, I will put the link after this session. But actually, this is presentation in Arabic, not purely in English. So it is in Arabic and English language. So I will go to another case scenario. Very
Sorry,
important.
Dr. Khalid.
Yes.
Sorry. For how long, if we take biotin, it will start to affect the thyroid function test? The duration of taking biotin?
Actually, this is depends actually on several factors. The first one is the dosage of biotin. If the patient, for example, in some cases like in multiple sclerosis, biotin can be prescribed as 300 milligram. For healthy hair, we can prescribe it as 10 or 30 milligram, and so on. So a dosage of biotin is very important. Another one is a duration. Once the duration is prolonged, you must suspect that it may affect it, can interfere with assay, thyroid hormone assay. And another one is creatinine clearance. If there is abnormal renal function, in this situation, the clearance of biotin will be prolonged, so we need to stop the biotin for a prolonged time. So actually, this is more. This is full details. Actually, is present in my presentation, which I mentioned previously when thyroid labs lie, and I mentioned that how to stop the biotin and when, because this is a very important recent topic actually. So I will go immediately to another case scenario. If anyone want to read this scenario. So we have 66-year-old farmer was incidentally detected to have abnormal thyroid function test when he was hospitalized. Once you see hospitalized word, you must suspect sick thyroid syndrome, the patient on dopamine, glucocorticoid, which will lead to decreased T4 TSH, or the patient on heparin, which lead to abnormal elevation of the free thyroid hormone. For a pulmonary embolism, so this is a sick thyroid syndrome or a patient on heparin undergoing anticoagulant therapy with low molecular weight heparin. So what you think about heparin? Leading to forced elevation of the free T4 and the free T3. What about the TSH? Will be normal. So which one of the following is the most in this immediate management?
Observe.
C.
Observe. So I want from each of you, when you read a case scenario, to pick up and highlight the most important words and put the differential diagnosis besides the case scenario. Hospitalized, so sick thyroid syndrome, so some drugs which can affect the thyroid function test. Pulmonary embolism, automatically heparin, which affect abnormally free T4 and T3. So this is abnormal results due to the heparin, which lead to clearance of elevation of the free thyroid hormone. So in this case, we must observe our case, not treat it or investigate it as coma or resistant to thyroid hormone, because this thyroid function test labs the same as thyroid TSH coma. TSH coma, the free thyroid hormone will be elevated, the free T3 will be elevated with normal TSH. Resistant to thyroid hormone, the same results. Spurious test result can be avoided by taking thyroid function test sample at least 10 hours after heparin injection and with immediate analysis of the sample. So this is very important.
Sir, kindly repeat what you said.
What?
You have told something about heparin to avoid.
Yes, yes. to avoid the heparin affection for free thyroid hormone, we can take a thyroid function test after 10 hours after the heparin injection. So if we take the sample after 10 hours of heparin injection and immediate analysis of the sample, this false elevation of the free T4 and T3 will be not presented in this situation. So الهيبرين will result in a direct competition of the free of T4 and T3 binding site, with more pronounced in the hypertriglyceridemia and hypoalbuminemia, which lead to elevation of the free T4 mainly and the free T3 in some situation. And in this situation, observe with a variety of the assay platform. Don't forget that the heparin effect has been observed with a variety of the assay platform like equilibrium dialysis, ultra centrifusion, and direct immunoassay. So, if a case in a case scenario mentioned that T3 and T4 is elevated, and you repeat the measurement with equilibrium dialysis and the same result, this is the heparin effect. If with equilibrium dialysis the results is changed and the free thyroid is the same from the same sample and the free thyroid hormone will be normalized, this is not a heparin effect, because there is some scenario they give a question like this: free thyroid hormone is elevated, and when they do this in equilibrium dialysis, the results return to be normal. This is not a heparin effect. This may be assay immunoassay interference. This is actually a very important topic, which is a rare genetic disorder of the thyroid hormone metabolism. And actually, in all exams, they will ask a question about resistant thyroid hormone, which is caused by mutation of in thyroid hormone receptor beta. And actually, in our exams, they ask about a mutation in the thyroid hormone receptor beta, which cause resistance to thyroid hormone. And this is a classical form for resistant thyroid hormone. Another recent updated topic in the Oxford, the 4th edition, which is inactivating mutation in the thyroid hormone receptor alpha, which is known as resistant to thyroid hormone alpha. This is a patient presented by growth retardation, macrocephaly, delayed closure of the fontanelle, delayed motor and mental milestone, constipation, mild normocytic anemia, excessive skin tag, and thyroid function test normal TSH, low free T4, elevation of free T3. So, if you have a case scenario, a patient with a growth retardation, macrocephaly, delayed motor and mental milestone, and normal TSH with low free T4 with elevation of free T3, the first one, you must exclude the thyroid hormone assay interference. After that, you can diagnose a mutation in the TRH alpha, which is resistant to thyroid hormone alpha, not beta. And this condition, an RT3 is decreased, and this patient can be treated by levothyroxine, because the free T4 is low, so we can give levothyroxine, and I will discuss actually it later, because I have a very important presentation about resistance to thyroid hormone, and I give this rare genetic disorder, and actually in the exam they love a question like this. Another one which is Allen-Herndon-Dudley syndrome, or monocarboxylated transporter 8 deficiency syndrome. This is X-linked disorder. What does we mean by X-linked? This is a male condition. So Allen-Herndon-Dudley syndrome usually presented by a male patient, presented by manifestation of hypo and hyperthyroidism, psychomotor retardation, speech and developmental delay, spastic quadriplegia, and also another manifestation of hyperthyroidism in the form of tachycardia and so on. And this is usually due to the MCT8 gene encoding defect. And this patient presented by is a male, presented by elevation of the free T3 with low free T4 with normal TSH, and can be treated by some drugs called triac and T3 analog. And actually I put a slide about this. So we have 3 genetic disorder important. The most important one is the resistant to thyroid hormone beta, which is caused by mutation in TRH beta. And another one which is caused by a resistant to thyroid hormone alpha, a mutation in TR alpha. Another one which is caused by defect in the MCT8 monocarboxylate transporter 8, which is Allen-Herndon-Dudley syndrome. Actually, these 3 disorders, I mentioned them in my presentation in the ThyroAlex previously, presentation called resistant to thyroid hormone, and I will give you the link for this presentation and can take some slides from it now. This is called as a syndrome with impaired sensitivity to thyroid hormone, defective transport, defect in the metabolism, and defect in the action. The first one in this situation, MCT8 defect, this is called Allen-Herndon-Dudley syndrome or MCT8 deficiency. This is the thyroid hormone cell membrane transport defect. This is mainly male with severe psychomotor retardation with a peripheral tissue hyperthyroidism. TSH is low, T4 is low, T3 is elevated, and reverse T3 is low. Another condition in which the adenase enzyme is defect, which is presented by gross delay muscular hypertrophy, hearing impairment, and azoospermia. Don't forget, because the clue is azoospermia. In this situation, TSH is elevated or normal, T4 is elevated, T3 is low, and reverse T3 is elevated. This is important because in the previous condition, reverse T3 is low. But in the thyroid hormone metabolism effect, reverse T3 is elevated. Another one which is resistant to thyroid hormone defect, action defect, which is resistant to thyroid hormone beta, which is a classical form due to the gene defect in thyroid hormone beta mutation, and another one resistant to thyroid hormone alpha, and another one called non-TRRTH, which is similar to RTA resistant, a classical form of resistance to thyroid hormone beta. I will give you some slides about this 4 conditions. And this Allen-Herndon-Dudley syndrome, this is a male presented by inability to talk and walk and decreasing metabolism in the poor weight, and mainly presented by manifestation of hypothyroid tissue like severe psychomotor retardation, and another tissue, thyrotoxic tissue, like increasing heart rate, sex hormone body globulin is elevated, creatine kinase and muscle volume is decreased, and the body weight decreased. So there is a peripheral tissue hyperthyroidism with severe psychomotor retardation and with the unique thyroid function test, and can be treated by symptomatic treatment. For example, if there is dystonia, we can give levodopa and carbamazepine and baclofen, and if the patient cannot take a food, we can give a feeding tube and so on, and we give intestinal physical activity. And as T4 is low, so we give supraphysiological dose of levothyroxine, but T3 is elevated, and I want to prevent the conversion of T4 to T3, so we give propionyl 3 times daily to reduce T3, and this is another indication, but this is a very rare condition. Don't suspect you can see this case scenario in your private, but in the exam it may be presented as a case, but resistance to thyroid hormone is more preferable than this very rare condition. And another treatment is by thyroid hormone analog. As T3 is elevation, with T4 is low, we can give the use of thyroid hormone analog that may bypass alternative pathway of the MCT8 gene, because this channel transporter is defected, so we can give thyroid hormone analog which can enter intracellular with another co-transporter, and this is the dosage of this drug. And another one can be treated by triac and track, which is a metabolite of T3 and metabolite of T4, but this drug is not approved by FDA. And another very important case condition, which is resistant to thyroid hormone. So resistant to thyroid hormone, الانسيدنس 1 to 40,000 population. This is a rare syndrome characterized by intact TSH responsive to TRH. As we mentioned previously, if we inject TRH, normally TSH will be elevated as normal. So thyroid hormone resistance, TSH responsive to TRH is intact. TSH will be elevated more than 5-fold. A patient present by goiter, short stature, hyperactivity, attention deficits, learning difficulty, disability. Don't forget goiter. The patient this condition is associated with thyroid hormone beta gene defect. This is a resistant to thyroid hormone beta, not alpha. Alpha is another condition, and most cases require no treatment. If needed, we can use just a beta blocker. Don't forget the main differential diagnosis is TSH secreting pituitary tumor. And this is demonstrates the same. This is a male with thyroid hormone beta gene defect, thyroid hormone resistance beta. And don't forget that in our exams, in every exam they ask, for example, in 21, they give a case scenario question for thyroid hormone resistance with positive family history. Don't forget that thyroid hormone resistance is gene defect. So there is they usually positive family history with high free T4 and normal TSH. So this family history suggestive of thyroid hormone resistance, not TSH shown. And differential diagnosis is very important, so we will discuss it later. And this is deadenase enzyme deficiency, functional D2 deficiency leading to normal elevation of the free T4 with normal decrease the free T3. Why? Because D2 is responsible for conversion of T4 to T3. If there is a deficiency of D2, what is the net result? T4 will be increased, T3 will be decreased, and the TSH will be normal because the deadenase enzyme has no role in the deadenase enzyme. And this mainly presented by male infertility, skeletal myopathy, photosensitivity. This is a selenoprotein deficiency disorder. And actually, this is a recent topic in the 4th edition of the Oxford Handbook. And another one, which is resistant to thyroid hormone beta, as we mentioned previously, it is the same as this is the beta. A clinical diagnosis mainly variable. The patient present by tachycardia, goiter. This is the main presenting symptom. Impaired negative feedback mechanism. So TSH is non-suppressed TSH with elevation of thyroid hormone. Abnormal cochlear development, affected color vision, impaired neural development, abnormal cerebellum and cortical learning. The patient is short stature, osteoporosis, attention deficit disorder. This is a resistance to thyroid hormone with a family history. This is slide is very important actually because this is how to differentiate between TSH and resistant thyroid hormone resistance. A clinical thyrotoxicosis in the resistant thyroid hormone, usually the patient is asymptomatic. But in the TSH the patient usually presented by mild symptoms of thyrotoxicosis. This is very important. In family history, usually present in the resistant to thyroid hormone because it is a genetic defect, but in the TSH no family history of similar condition. Alpha subunit is very important. It is elevated in TSH, but it is normal in resistant to thyroid hormone. What is most important in alpha subunit? Alpha glucose glycoprotein subunit molar ratio over TSH. So molar ratio of alpha glycoprotein subunit over TSH, this is more significant, and it is elevated and presenting about 80% of TSH shown. So alpha subunit is elevated, and alpha subunit molar ratio to TSH. In patient with intact thyroid, this is the most sensitive test to identify TSH shown. Don't forget this, because in the exam may ask about alpha subunit and another laboratory value, which is the most sensitive. الالفا subunit, المولر ratio. البيتيوتري MRI actually TSH in most cases it is a macroadenoma, But in resistant to thyroid hormone, it is normal pituitary, but don't forget, maybe pituitary is induthaloma. And this is a common condition. So we cannot differentiate between an RTH with TSHoma according to the MRI alone, because it may be non-functioning pituitary adenoma in patient with resistant to thyroid hormone, and you manage it as TSHoma, which is incorrect. Another one is sex hormone bioglobulin, which is elevated in the TSHoma and normal in the resistant to thyroid hormone. Very important test, which is TSH response to TRH, which is in this situation in the TSHoma a blunt response, no change, but in the resistant to thyroid hormone as normal, TSH will be increased. And this is a most specific test for diagnosis of TSHoma, a blunt response. This is very important because in some exam ask about a blunt response presenting which condition, TSHoma. Another one, TSH response to T3. If we inject T3 for a normal person, what about the TSH? Will be decreased. This is a physiological response, physiological negative feedback mechanism. So resistant to thyroid hormone, the same as normal. If we inject T3, TSH will be low, decreased. But in TSHoma, if we inject T3, TSH will not be changed. And this is another very important test to differentiate between resistant and TSHoma, and this is the most accurate test to differentiate between TSHoma and RTH syndrome. But this test is contraindicated in patient elderly or any patient with coronary heart disease. You inject the same drug as levothyroxine. So levothyroxine, we should start a small dose and increase it gradually in a patient, elderly patient or a patient with coronary heart disease. And another one, falling TSH on octreotide. Octreotide, as we mentioned previously, if we inject octreotide, will be suppressed TSH. This is a diagnostic for TSHoma and no change in RTH. This slide actually is very important, because in all exams they will ask 1 or 2 questions about TSHoma and resistant to thyroid hormone. 1 or 2 or 3 questions about from this slide actually. So the MRI pituitary is very important, but the most important one is alpha subunit. And another one, a blunt response to TSH response to TRH will be no change in the TSHoma, increase in the RTH. T3, if we inject T3, TSH will be decreased in the RTH and will be no change in the TSHoma. So how to diagnose the resistant to thyroid hormone? Clinically, the first one, goiter, psychological abnormality, tachycardia. Another one, laboratory test, thyroid hormone, both thyroid hormone is elevated with non-suppressed TSH. And lastly, genetic testing. We have 10 minutes and rejoin the session. Patients suspect to have RTH. This is we must repeat the test to exclude the hormone transport defect and check thyroid function test in the first degree relative if the same condition. So this is with resistant to thyroid hormone. If normal, we measure the alpha subunit. If the alpha subunit elevated, we should investigate for TSHoma doing MRI pituitary. If the alpha subunit is normal, so in this condition we should perform Werner test, which is T3 suppression test. We give T3, TSH will be decreased. This is a resistance to thyroid hormone. And if TSH suppressed, we should do genetic testing to confirm the diagnosis of resistance to thyroid hormone alpha. And actually, as we mentioned previously, a treatment of resistant to thyroid hormone, we must diagnose it correctly. Because of diagnosed hyperthyroidism, we can give antithyroid medication or radioactive iodine or do a surgery in puberty, and in this condition the symptoms will be worsened. And this is actually the algorithm how to manage resistance to thyroid hormone beta, but actually in our level no treatment is required in most patients. But if you want more details about this algorithm is from the thyroid and its disease. According to the TSH elevation, we can give thyroxine for some condition of the TSH elevation by some criteria, and also we can give another drugs like triac, or we can give another drugs. So this is not very important. the treatment of resistance to thyroid hormone beta usually symptomatic treatment. No treatment is required in most cases. Alpha resistant to thyroid hormone alpha, this is a rare condition due to the loss of function mutation in the thyroid hormone resistant alpha. And the patient usually presented by low T4, elevation or normal T3 with normal elevation of the TSH, very low reverse T3. Clinically, the patient had a variable condition. The bone may be developed, delayed development, may be presented by chronic constipation, may be presented by impaired neural development, abnormal cortical layering and cerebellum development, and bradycardia. I know that this condition is rare, and someone can complicate it from these numbers and this value of TSH, and I think all thyroid function tests mixed with each other. But if you repeat these numbers several times, you can memorize it actually. Usually medical knowledge need repetition and need to write it more than once. How to treat it, thyroid hormone resistant alpha, as we mentioned the previous, by levothyroxine. And this from the thyroid and S disorder textbook, classification of this syndrome and thyroid function test value in each condition. So I will go to another section, which is drug and thyroid summary, and this table I collect it actually from a lot of resources, and you need to memorize it several times. So الاميودارون, recent intake of the amiodarone can lead to increase in level of the TSH with elevation of the free T4 with low normal T3, which mimic TSHoma or thyroid hormone resistance. What is the most important? Lithium cause hypothyroidism, elevation of the TSH. الفينيتاين, as we mentioned, BC-BRAS اللي هو enzyme inducer leading to low T4. The same الكربامازepine. Don't forget the heparin leading to elevation of the free T4. This is the mimic TSHoma, thyroid hormone resistant. And don't forget the biotin, mimic primary hyperthyroidism, TSH is low with elevation of thyroid hormone. And don't forget the estrogen, and another factor that increases TPG will lead to increase total thyroid hormone and has no effect on the TSH. This is very important actually. Familial hyperthyroxanemia, familial dysalbuminemic hyperthyroxanemia. In this condition, actually, the free T4 will be elevated with normal free T3, but in some condition, the free T3 may be elevated. So don't forget, in the familial dysalbuminemic hyperthyroxanemia, the total and the free T4 will be elevated. The free T3 with total T3 may be normal, reverse T3 will be elevated. And this is confirmed by protein electrophoresis of the serum containing label T4. So a familial dysalbuminemic hyperthyroxanemia, this is autosomal dominant condition. So mutation in the albumin gene caused by abnormal albumin molecular with increased affinity of the serum thyroxine despite the serum albumin level being quantitatively normal. So in some previous exams, they asked a question in 2019 about the elderly gentleman with normal TSH with high free T4 and normal T3. This is a mimic. This is the same as familial dysalbuminemic hyperthyroxanemia. The patient is asymptomatic. T4 is normalized on equilibrium dialysis. So I suspect this condition is HDH syndrome, not heterophil antibody, because as we mentioned the previous, heterophil antibody will not improve with equilibrium dialysis. Another very important interference, which is heterophil antibody, and actually if you review when thyroid lab slide, you will take a lot of data about this interference. And what is most important in this condition, this will lead to elevation of the TSH with normally free T4 and T3, and may be causing elevation of the free T4 and T3, and this is very important. So this is exam previously and maybe in some condition TSH is not normal. So in the previous exams they give a question about TSH is elevated and the patient is given thyroxine but TSH is not improved. This is usually non-compliance. But if you excluded non-compliance, you must suspect this is a heterophil antibody interference. And actually, in when thyroid labs lie, I give a case scenario like this. TSH is elevated, and so we diagnose it as a primary hypothyroidism, and we give thyroxine. But later on, the patient is not improved as a TSH. The free T4 is elevated more than normal. TSH is still elevated, so this is a non-compliance. We excluded non-compliance, so this is a heterophil antibody. And actually, this algorithm demonstrates the different type of interference. The macro TSH will lead to increase TSH. The heterophil antibody will lead to increase TSH. The biotin lead to decrease TSH with elevation of the free thyroid hormone. Thyroid autoantibody. Actually, I don't know to complete or to stop. What?
Complete, Doctor.
Okay. Thyroid autoantibodies is a
Complete.
marker of autoimmune thyroid disease. Once you see anti-TPO or anti-TG or TSH receptor antibody, this means this patient have an autoimmune thyroid disease. Autoimmune thyroid disease means what? Hashimoto thyroiditis, atrophic thyroiditis, postpartum thyroiditis, Graves disease, and the Graves orbitopathy. This is the autoimmune thyroid disease. So the most important that TSH receptor antibody and its prevalence. TSH receptor antibody is pathogenomic for Graves disease, presenting in 70 to 100% in a case of Graves disease. Don't forget this number because in some exam they ask about TSH receptor antibody in a patient with Graves disease. And also a TSH receptor antibody may be stimulating, causing Graves, and may be blocking antibody causing hypothyroidism, and this is represent about 10 to 20%. So a TSH receptor antibody may be stimulating antibody in a Graves disease or blocking antibody in cases of autoimmune hypothyroidism. The anti-PPO is presenting in Graves disease in a percent of 80%, and this actually a previous exam question. The autoimmune hypothyroidism, the anti-TPO is present in about 95% in a patient with autoimmune hypothyroidism. And this is very important. All exams will ask about some sort of this percentage, but you should. So I will continue. Don't forget that this anti-TPO and the anti-TG may be presented in a normal individual. So in about 5 to 25% of the general population, the anti-TPO is positive. But in the patient with Graves disease, the anti-TPO is present in about 80%. The TSH receptor antibody is present in 0% for the general population, but it present in the Graves disease in about 95%. The anti-TPO is present in the autoimmune thyroiditis in about 100%. Even the relevant of the patient, the anti-TPO may be present in about 50%. The type 1 diabetics, the anti-TPO is positive in about 40%. So the all guidelines recommend assessment of thyroid status, the anti-TPO and TSH in all patients of type 1 diabetes yearly. And even in the pregnant woman, the anti-TPO is present in about 14%. So a number here is important because some questions ask about this number. The pathogenic role of the main thyroid autoantibody, TG antibody, pass placenta to the baby but have no effect on the fetal thyroid. TPO also pass placenta, also has no effect on the fetal thyroid. But TSH receptor antibody trans placenta and cause fetal hyper or hypothyroidism. So this is very important during pregnancy. Mother with anti-TPO, mother with anti-TG, no bad impact on the fetus. But if the TSH receptor antibody is positive, so the fetus may be presented by fetal hyperthyroidism or hypothyroidism. Even if the mother of a Graves' disease and treated previously by radioactive iodine or surgery, a TSH receptor antibody will be presented for several years and can pass placenta and affect the fetus. And this is very important to how diagnose and how to manage this condition. And we will discuss it in another session when we discuss thyrotoxicosis with pregnancy. So what is the important role of the thyroid antibody in the clinical management? A TG antibody diagnose thyroid autoimmunity. Just the patient, if he presented by anti-TG antibody positive, this is thyroid autoantibody, and have a very important role in the follow-up for differentiated thyroid cancer, which can predict recurrence, and also has a role in predict which can interfere with the thyroglobulin, which is a tumor marker. So in any patient with differentiated thyroid cancer, follicular carcinoma or papillary carcinoma, how to manage? Mainly surgery, then suppressive therapy, then radioactive iodine. How to follow? By TG, thyroglobulin, which is a tumor marker. If TG is elevated, so it means the recurrence of thyroid cancer. But TG assessment, if there is anti-TG antibody, this can interfere with the TG assessment. So in each time you assess thyroglobulin, you must do thyroglobulin antibody. And this is a unique for a thyroglobulin antibody. A TPO antibody diagnostic for thyroid autoimmunity, infertility and pregnancy may have a rule, even if the patient with normal TSH, and can predict postpartum thyroiditis. Also, TPO, if present, can differentiate between type 1 and type 2 amiodarone-induced thyrotoxicosis. In type 1, anti-TPO antibody may be present. In type 2, anti-TPO usually negative. And a TSH receptor antibody, it is a diagnostic for Graves' disease and Graves' orbitopathy, and can predict neonatal thyrotoxicosis, and also can differentiate between amiodarone-induced thyrotoxicosis type 1 and type 2.
Dr. Khalid, how will we suspect that we should do thyroglobulin in thyroid cancer? How we should suspect that there might be thyroglobulin antibody present?
By assessment of it. By assessment, each time you do thyroglobulin for follow-up of patient with differentiated thyroid cancer, you should do anti-TG. If the anti-TG is negative, positive, for example, you suspect if TG is low, it may be a result for this antibody, not means no recurrence.
No recurrence.
So in another situation, if you have TG antibody titer and the antibody titer is elevated, what does it mean? Recurrence of differentiated thyroid carcinoma. So we need to diagnose the recurrence by elevation of the TG antibody titer and as reading of thyroglobulin value with a TG antibody. Dr. Khalid ask about question anti-TPO antibody linked to recurrence of abortion even with euthyroid female. Yes, this is correct one, but this is not very strong evidence about this. So previously, and actually we will discuss it later, management of TPO positive with normal thyroid function, how to manage, because this can affect pregnancy, infertility, and can cause recurrent abortion. Give steroid or not? Sure, no rule of steroid for anti-TPO positive female, but we can give a small dose of levothyroxine. But there are a lot of recent trials that show that levothyroxine has no role for this if TSH is less than 4. If less than 2.5, not 4. Dr. Zaki asked a question, how to deal with a child 13 years with autoimmune thyroiditis, euthyroid function, so TSH is normal, but patient have symptom and goiter by ultrasonography and positive TPO. Actually, we manage hypothyroidism according to the TSH, not other parameters, because all symptoms of hypothyroidism is non-specific. The patient present by weight gain, present by dry skin, hair loss, bradycardia, menstrual irregularity, for example. This all manifestation is non-specific for hypothyroidism. So we cannot treat this condition by levothyroxine. Levothyroxine is treated only if the patient is TSH is elevated. If it is subclinical hypothyroidism, and in your case, Dr. Zaki, we can treat this patient as a positive TPO, and there is symptoms may be suggestive of hypothyroidism, and there is a goiter. But if it TSH is more than 10, we must treat. But if it TSH is normal, no need for replacement therapy. What about the thyroid enlargement? This is a physiological enlargement. The patient is compensated. And usually this mild elevation is minimal. The role of non-steroidal and non-steroidal anti-inflammatory drugs only in preaquiral thyroiditis, subacute thyroiditis. If there is a pain, tenderness, in this situation, we must give non-steroidal anti-inflammatory. If severe pain, it will respond immediately to the steroid therapy. And actually, this way we will discuss in a session of thyroiditis. So Hashimoto thyroiditis is a painless condition, but subacute thyroiditis is a painful condition. Pain need non-steroidal anti-inflammatory drug. To give thyroxine only if the patient is TSH is elevated. We will go to another question, very important question. Who will answer this question? And as we mentioned previously, read the head of the question. Yes, thyroid ultrasonography, we will discuss it, Dr. Najah.
Type 2 deadenase.
Which one, C or D? Both C and D type 2.
Leading
D,
to
increase this 3.
leading to increase the T3.
Yes, this is
D.
correct.
D.
So this is very important because in the neuron, D2 lead to increased T3. In the liver, in the kidney, D1 will increase T3. Okay, this is very important. D3 leading to increase reverse T3 and present in the placenta. So this is very important. This is 5-dehydrogenase enzyme. This slide is very, very important. Screening of thyroid disease, this is a controversy to screen, whom to screen, and actually about 10% of subclinical hypothyroidism and 1% of subclinical hypothyroidism can be presented asymptomatically. What? The prevalence of unsuspected overt thyroid disease is low, but substantial proportion of subjects tested will have evidence of thyroid dysfunction, with 10% of subclinical hypothyroidism and 1% of subclinical hypothyroidism. So if we do a mass screening, so this is a recommendation to whom to screen. A recommendation is screen every female less than 50 years, and in female is not warranted routinely, but you should do screen the female during the menopause if there is a manifestation or non-specific symptom which is should justify according to the clinical situation. If it TSH is elevated, we should repeat it. We do in another situation of 84 with after excluding of non-thyroid illness and drug. The treatment of levothyroxine, if it TSH is more than 10, we must treat by levothyroxine for the young patient. But for the elderly, if it TSH is more than 10, we only treat if symptomatic. If the TSH between 5 and 10, in this situation with normal 84, this is subclinical hypothyroidism, we should repeat thyroid function test within 2 to 3 months. If it is elevated, the risk of development of hypothyroidism is increased, and in this situation, TSH should be assessed at least every 3 years. If suppressed TSH is found at screening, we should measure after 2 months repeated TSH with T4 and T3. After levothyroxine, we should do annual measurement of TSH as a follow-up. The following category of patients should be screened routinely. The value of screening for congenital hypothyroidism is must in all population. This is a heel break test because the prevalence of congenital hypothyroidism is 1 to 2,000 in the newborn. This is very important, and early management prevent a neuroconjunctive dysfunction. But no consensus on whether healthy pregnant female to do screening or not. But if the patient with goiter, AF, hyperlipidemia, subfertility, osteoporosis, we should screen. We should annually screening for type 1 diabetes mellitus appears cost effective. For female with type 1 diabetes, in the first trimester we should do screening for thyroid function test and post delivery, because in postpartum thyroiditis is increased 3-fold more than general female. Also, in any patient with amiodarone, lithium, interferon, we should do assess thyroid function test before administration of this drug and within 3 months of initiation, and then every 6 months for 2 years, and then yearly. And also within 3 months of initiation of immuno checkpoint inhibitor therapy, which is a very important topic, because in our exam there is a question about immune checkpoint inhibitor and we will discuss it later. Female with past history of postpartum thyroiditis should be screened. Also, we should do annual TSH for patient with Down syndrome, Turner, and autoimmune Addison, and also in a patient with head and neck radiation. This is very important. Any patient with Turner, Down, autoimmune Addison, head and neck radiation, we should do annual screening by TSH. All patients with hyperthyroidism with receive ablative therapy should be followed indefinitely for development of hypothyroidism. And in some question, they ask about the risk of hypothyroidism after radioactive iodine, and it will be discussed later. Beginning 4 to 8 weeks after treatment, and then at 3 months interval for 1 year, and then annual. This is the patient with receiving ablative therapy. Don't forget that in hospitalized patient for acute illness, don't test for thyroid function test to avoid diagnosis of non-thyroid illness, except if there is a very high suspicion of thyrotoxic crisis or myxedema coma. Actually, Dr. Zaki, if the goiter is 7 to 8 centimeter, this is a enlarged goiter, and in this situation, if we should suspect lymphoma, for example, lymphoma presented by rapidly enlarged thyroid gland, so we should screen for it. Also, a goiter may be presented by a huge goiter in a patient with iodine deficiency, so we need to exclude the iodine deficiency according to the situation of the case. But a goiter 7 to 8 centimeter, this is a large goiter which may cause compression, which may need surgical intervention if there is a compression. This number is very important. Female patient with thyroid antibody, the risk of development of hypothyroidism increased 8% over 20 years. Female with thyroid autoantibody and isolated elevated TSH, 38 risk of development of hypothyroidism with 4% annual risk of overt hypothyroidism. So any female patient with positive autothyroid antibody, we should screen by annual TSH. Maternal thyroid antibody are associated with recurrent miscarriage and preterm birth. Levothyroxine in the euthyroid female with positive anti-TPO did not increase the rate of live birth, and this is recent according to the tablet guideline, the tablet study actually. And we will discuss it in the presentation with thyroid disorder during pregnancy. Another very important topic, which is scintigraphy. And actually, I would like to still we have just I will try to decrease the slice in the next presentation. Actually, I cannot complete this presentation today, so we can complete it in the midweek actually. So to go with our schedule, we can do it inshallah to complete this session after 2 or 3 days.
Yes. Yes, because another topic, thyroid scan and ultrasonography need very important and need to discuss it in next.
So to complete or to stop now and complete it after 2 or 3 days?
Yes, complete it after 3 days.
I think we
Yes.
can
دكتور من فضلك يعني
stop today.
السلام عليكم.
Once again.
مع بعد إذن حضرتك هو إحنا يعني إن شاء الله كده عارفة إن إحنا هنكمل بإذنك يا رب، بس هو حكاية الفيز دي هتبقى مهمة عشان بس نبقى عاملين حسابنا. عايزة أعرف بس مواعيدنا هتبقى إمتى؟ يعني هل إحنا مثلًا هنبقى محاضرتين في الأسبوع، واحدة في الأسبوع، عشان بس أبقى يعني كلنا بنشتغل
Actually, in most cases, one session every week. Of course, في some weeks maybe some social conditions, so I cannot يعني every week. So according to our conditions, but actually because this is very important and already completed, I will complete it in the midweek. So I will post a survey and choose the day most of our attendees selected. About the fees, I mentioned that the fees is not determined yet. Everyone is welcome, and I want
بس ده حق
to say
حضرتك
that
حق حضرتك طبعًا.
the fees is not
يعني
a barrier for joining this sessions.
But Dr. Khaled, you will have to be paid for your services now.
Yes.
You have to. So how is the fee? I will after this session, or I can postpone it after the midweek session. I will give a survey and everyone put the suitable and fees and then I will discuss it. When to pay, this is not actually urgent. Don't put this in your mind. If anyone want to pay after 2 or 3 sessions or even after the end of full thyroid sessions, I will accept this. And even after the full sessions of the thyroid and want not to pay, it's okay. So this is not the issue. I want not to put this or to some extent مش عارف يعني مش عايز نقطة الفلوس يعني تمثل مشكلة لأي حد خاصة الأطباء الصغيرين أو يعني في النهاية I want to mention that أي حد عايز خصم بأي نسبة it will be accepted so I will not exclude someone from joining us. Also I don't know, but little fees later on, after complete of some sessions, even after 1 or 2 or 3 weeks, this is accepted from me. But I will show what is the remaining, because actually in every session I will put some questions like this at the end, so I will stop in scintigraphy. And at the end of
Okay.
the session, of each session, actually, I put some hints, some question like this, and give some the summary of the presentation, some slides like this, and then I want to go to a question program and solve 15 questions, but I will postpone this to the midway session. And I will end by this slide. If anyone have conflicting point, please send them through WhatsApp, and I will try to clarify them in the next presentation. And also, if you have any remarks about how this course runs in the next sessions, please let me know. So if anyone, for example, not need interactive cases in between slides, or just follow Oxford Handbook, I will accept this if all or most of the members accept this. So all things will be accepted actually. So actually this is the program which we will actually I prepare some question like this, and inshallah in the next presentation we will try to solve this 15 question and ask about, but we can at least we can answer this question only. We need actually to get benefits from this presentation to be interactive. So
Tamoxifen.
what? Which one?
Tamoxifen.
Yes, which one is the
رقم E tamoxifen.
the tamoxifen?
Tamoxifen.
This is the correct one. Yes, this is the tamoxifen. So actually in
tamoxifen رقم E.
yes, this is the correct one. So inshallah I will complete and I will repeat fees. Don't put it in your mind, just we can discuss it later. I don't want anyone to send fees until at least we decide how much for the thyroid chapter actually. And also if anyone want any discount, I will accept this. This is not a problem for everyone. Don't put it as a barrier, because I know socioeconomic there are some socioeconomic factors affect anyone. I know that there are junior doctors, there are training doctors, so these doctors we must respect them. So it is I will end it now, and actually I don't know when I upload this presentation, because it is multiple videos and I want to join them and re-upload them. So I will upload once they finish, and inshallah you can decide. We can do it in the which the next day midweek, or if you want to postpone it to the Friday, it will be accepted.
Dr. Khalid, you
Friday?
do
Friday?
convenient.
Friday?
Yes.
Okay, so I will complete this presentation. Yes.
So this will be
So
very lengthy then.
I am democratic. I will post a survey, and according to the suggestion complete يوم الثلاث اللي انا مش عارفه يوم ايه بالعربي بالانجليزي. ولا Friday. So I will post a survey immediately after this presentation, and according to the results of this survey, I will continue in the Friday or Saturday, Sunday, Monday, Tuesday. Okay.
Dr. Khalid Yusuf, please share the link. Share the link of YouTube of resistant to thyroid hormone presentation.
Yes. Actually, I will post the two links, and I mentioned that this is very important, and I actually I give it as a gift, extra gift. This is the two presentation, so I can post them immediately after this presentation. The link for resistant to thyroid hormone, and actually this is in English, and with thyroid hormone labs, and this is in Arabic actually, but I can take it in another time. So thanks for all, and I hope everyone is okay. And actually, for the persons who will appear in the after less than 1 month, I will prepare a revision session for the thyroid. Actually, diabetes and another session is very difficult to prepare today. Actually, every session need a lot of time to prepare. And actually, have today I have some sort of common cold, so excuse me. Thanks for all.
Thank you,
Thank you,
Dr.
Dr. Khalid. Thank you, Dr. Khalid.
Later.
Thanks, Dr. Khalid.
السلام عليكم.